So time to Cmax, so 3.2 hours, half-life 6 to 8 hours. So normally the drug's given 3 times a day. It's excreted in the kidneys, so once again, renal function is important to know. The site of action is really this alpha 2 subunit, so it affects calcium channels. And I mean, that's how a number of the older anticonvulsants work as calcium channel blockers. One open study of 22 patients treated with gabapentin achieved a pain reduction from 6.4 to 3.2. This is with neuropathic pain, of course. And the average dose was only 1,000 milligrams. So that's not bad. That's not a bad reduction in pain relief on a visual analog scale. 59% achieved more than a 50% reduction in pain. And there's interesting work coming out with the addition. So you've got a difficult pain problem with the actual addition of gabapentin to opioids. So they seem to have a synergistic effect. And then pregabalin or Lyrica is also available. But we seem to have more difficulty getting pregabalin. And I think they can get it, Ralph, you were telling me about this through the pain clinic. The pain clinic can get it? Yeah. We can't get pregabalin. We can get hold of gabapentin through the hospital. You can prescribe it privately, of course, but it's expensive. There's other membrane stabilizing drugs that you can look at for neuropathic pain. Certainly, when I was a registrar, valproate was the flavour of the month. So we used to put a lot of patients on Epilim. I guess the decade before that, Tegretol, and probably the decade before that was Dilantin. You can also look at antiarrhythmics. Mixilotine is a lignocaine-like drug, and it's certainly been used for neuropathic pain. But I must confess, over the last few years, I've probably used valproate a couple of times, and I've not used Dilantin or Tegretol, and I haven't used Mixilotine. But when I was a registrar, we used to use Mixilotine or valproate. Now, adding a steroid in may be useful for neuropathic pain if there's any neural compression. If you've got neural infiltration, we talked about those terms last week, but if you've got neural compression, then you may well get significant relief. You know, say you've got a lumbosacral plexopathy with a recurrent rectal tumour pressing back against the lumbosacral plexus, then steroids may be quite useful. You mightn't have many other options. So if you had, say, a using the example of rectal cancer, they may have had radical radiotherapy there, then there's surgery and chemotherapy, and now they've got a recurrence. Well, you're stuck. Steroids orally, if they can take it, yeah. Well, classically, we use dexamethasone. It's a more potent drug, but I mean, you could use, it's a 7-to-1 from prednisone, as you know, so you could just use a bigger dose of prednisone, I guess, if you wanted to. Dexamethasone probably does have a longer biological half-life, so you can get away with giving it once a day, as you can with prednisone anyway, I suppose. But what dose do you give? I don't know. I guess I'd probably use, a larger person, probably 8 milligrams. A smaller person, I'd probably give 4 milligrams. I think the combination of the opioid and the non-opioid membrane stabilizing drug seems to be the way to go. I guess like a lot of things, you get a couple of papers that come out and they seem to be good, and then someone else does it and it's not quite so good, and then they do a comparative with other therapies, do a sort of like a phase 4 trial. I think we're still learning a lot about those combinations of those drugs for nerve pain. But it's certainly not a bad thing to do. The lignocaine mixilotine for refractory pain. Lignocaine has been shown to be more effective than placebo in opioid refractory pain in cancer patients. So this is with an IV infusion of lignocaine. And if I recall, this study was an Indian study. Last year I went over to the Indian Palliative Care conference, and there was a few speakers that actually spoke about the use of lignocaine anaesthetists. So when they had very difficult pain problems that weren't responding, they would give a trial of lignocaine. The mean duration of analgesia was a few days, which was significantly longer than placebo. Side effects, as mentioned there. If the infusion of lignocaine was effective, the dilemma was whether to continue with intermittent infusions or consider mixilotine. And that's something that we really don't know all that much about. However, there is a study, this is a different study, looking at mixilotine, and this was in a very large population. And because this is the theory that if you give lignocaine and it works, that mixilotine should be able to work better in those patients. So you've actually selected out a group of patients where that particular type of drug is helpful. What they looked at in this study was the time to discontinuation. So a patient who'd responded to lignocaine, they got put on mixilotine. How long did they stay on the mixilotine for? With the theory being that the longer you stayed on the drug, the better the drug was for you in terms of efficacy and side effects. So what they found was that the time to discontinuation from the commencement of mixilotine in lignocaine responsive pain was a median of, 6 weeks. And longer times were predicted in patients who had a better response to lignocaine, were of male, gender, and younger age. But, that's not a long period of time. And often the trouble with any pain studies is the duration, because it's otherwise, you've got to follow up. A lot of pain studies are for 2 weeks. That's it. So what happens in 2 months? And dorsal horn inhibitors, so these are the antidepressants. Talked about gabapentin, clonazepam. Clonazepam, actually, I think next week we talk a bit more about, or there's a trial with clonazepam. Baclofen may be a useful drug. Oh, here we go, clonazepam, it's here again. Recent very small study, titrating up from 0.5 of a milligram to 2 milligrams on morphine and as well as clonazepam, and the pain decreased from a median of 3 on day 0 to a 1, and this was a different pain score, okay? So obviously severe pain reducing down. I don't use clonazepam for neuropathic pain. Why? I think it's too sedating. Antidepressants. So there seems to be this analgesic effect before you get relief of concurrent depression, or maybe the patient's not depressed. It's an effective analgesic dose is usually lower than that required to treat depression. But I think what happens is that we fall into the trap and we think, a little bit of tricyclic and that's all we do. And I remember talking to someone who was quite expert in neuropathic pain, and they said if they could, they would titrate the dose up to levels that we would use for treating severe depression. So, we might think about using doses of 25 or 50 milligrams of, say, amitriptyline a day. And he was saying, well, if you're not getting relief at that level and the patient can tolerate the drug, you should titrate it up to doses of, 150 or more milligrams a day. So if you're going to get a response, usually you get it within a few days rather than a week, or rather than a fortnight or 3 weeks, as you might expect with in terms of getting effects on depression. And it, like the other co-analgesic, appears to have an additive effect with morphine. Amitriptyline has a dose-response curve for its analgesic effect, so hence the reason to try and push the dose up if you can. Adverse effects we all know, so sedation, dry mouth, orthostatic hypertension. If someone's got heart block, you're obviously of some concern because of the potential cardio toxicity, and appears to be equally effective from different types of neuropathic pain. A recent open label trial with mirtazapine, so one of the newer drugs, not a tricyclic obviously, showed a trend towards improvement in pain and other symptoms including insomnia, anxiety, nausea and appetite. Depression and quality of life showed a significant improvement over baseline, and they felt that there needed to be a randomized controlled trial to look at its use in neuropathic pain.